Introducing Altivity, Canon Medical's bold new approach to AI innovation. Using only the latest AI technologies, Altivity lays the foundation for a smart and ambitious future, powered by advanced AI capabilities. High-quality images for enhanced diagnostic confidence and informed treatment decisions. Reduced exposure dose with fast, accurate results for a more tailored treatment approach. Simple, streamlined workflows that optimize resource deployment and increase efficiency. Because when you turn your data into a truly essential asset for you and your patients, the possibilities are endless. Altivity. Intelligent healthcare made easy.
Good morning, good afternoon, or just hi, and welcome to the Canon webinar Altivity, Outcomes-Driven Innovation in Stroke. I'm so happy and glad you joined us, because we are today talking about topics of absolute importance in the field of radiology and beyond. And I'm also happy to have three really excellent speakers on our topic. Without further ado, I would like to introduce Professor Peter Chang to you. He is the co-director of the Center of Artificial Intelligence and assistant professor in residence at the University of California in Irvine. He is one of the major leading scientists in the area of AI in radiology. I'm so glad he joined us today. He's going to talk about advanced stroke triage with artificial intelligence. I'm so happy to receive your talk. Please, the stage is yours.
Thank you very much for that introduction. And as you might imagine, of course, this is an absolute pleasure of mine to be here with you today. Thank you very much for the invitation. As was introduced, I am a radiologist with a background in full stack software development and AI. And with that background, I'm going to talk to you today about stroke triage with deep learning, emphasizing, of course, a lot of the imaging components of stroke care. We have a great lineup for you here with clinicians and other stroke experts following myself. So I'm going to just set the stage with imaging-based evaluation here. These are my disclosures, including the fact that I am, in fact, co-founder and CMO of a startup company, Avincina, that works closely with Canon Medical to develop stroke AI solutions. All right, so what do I mean here when I talk about stroke imaging triage? Well, if a patient comes in for suspected stroke, in fact, there are a number of key decisions that will need to be made based on imaging to ultimately determine optimal therapeutic options. These include, first, the exclusion of acute hemorrhage on non-contrast head CT. Patients without a hemorrhage are then triaged and moved on to the next step of evaluation, which is to identify a occlusion or a thrombus in a very specific portion of the proximal circle of Willis. That's number two. And then finally, patients with the right type of potentially treatable thrombus are then evaluated and characterized for the extent of ischemic core. And this is done either through what's known as an aspect score, as we'll see shortly, or through CT perfusion. Now, it turns out that each one of these key imaging-based triage steps, which again are well established here in the clinical workflow, each one of these represents a potential opportunity for AI-enabled quantitative evaluation. Now, before I dive into the precise details, I will mention that this talk is very brief. I'll only cover some high-level details. If you would like to know more, this is an excellent overview our team has recently published on each one of these applications across many different vendors in a very neutral way to get highlight and provide a summary of what's available here in this area of evaluation. As a starter here, I'm going to show you two videos of applications in use at our hospital. One is the evaluation of acute hemorrhage on the left, and on the right-hand side of the screen, you will see a tool evaluating large vessel occlusion. And what I want to draw your attention to as I press play is the speed at which an AI algorithm is able to go through a busy work list like you see here and quickly identify the small number of positive patients here with a red dot in both of the two work lists. This occurs in a matter of seconds. And as you see, if you click on any of the identified positive patients and scroll through the exam, you will in fact confirm the presence of a small amount of subarachnoid hemorrhage at the brain vertex on the left-hand side, as well as the presence of a proximal M1 occlusion here on the right-hand side of the screen. These findings, I will acknowledge to a trained expert, are not difficult to identify, but in fact, the speed at which I'm able to go through and identify the relevant positive exams, right? That type of rapid identification is in fact the key workflow efficiency that's gained through these type of triage applications. Along similar lines, the AI algorithm is able to send us notifications in real time of positive findings, further, again, enhancing that ability to alert and attend to patients in need of evaluation first. These are examples of email messages that the AI can send. Similar types of integration are also available on your mobile phone as well as your text page system in the hospital. With that in mind, I'm going to cover each one of these applications in just a little bit more detail. The first application, as you recall, is the exclusion of acute hemorrhage on non-contrast head CT. Our algorithm for this first goes through and identifies a number of candidate regions within the brain that contain suspicious areas of apparent high density. A second algorithm then goes through and carefully evaluates each region for the presence or absence of true hemorrhage. True hemorrhage, as identified in panel D here, is then further evaluated with a final algorithm to create very precise segmentation masks for hemorrhage volume. This algorithm is extremely accurate. An initial series of 10,000 exams not used for algorithm training yielded a sensitivity of over 95%, just 26 missed cases out of 900 positive exams. The algorithm was furthermore very accurate in the quantification of hemorrhage volume. The DICE score shown across 3 different compartments here, a metric of spatial overlap is quite high across the different compartments. And importantly, the Pearson correlation of volume estimates ranges from 95 all the way up to 99% correlating in the intraparenchymal compartment. By comparison, a more conventional ABC/2 measurement, which is dependent on manual 2D measurements of the hemorrhage, have a Pearson correlation of only 95% with ground truth, on average overestimating the true hemorrhage volume by 20%. By comparison, the AI-based method here reaches within about 2% of the average true hemorrhage volume, much more accurate again than conventional one-dimensional, two-dimensional estimates. These are a few examples of algorithm predictions, notably true positives on very small and subtle hemorrhages. You'll notice again here that the algorithm is very sensitive. Hemorrhage can be perhaps just a few millimeters in size, covering a small portion of the brain, things that realistically can be missed in a busy clinical practice, even by expert humans. Our AI, as you see here, is able to successfully pick out many of these types of small hemorrhage volume. No algorithm, of course, is perfect. These are examples of false negatives and false positives. Starting with the false positives in magenta here on the left-hand side of the screen, you'll notice that most of the time these false positives occur due to beam hardening artifact or other types of artifact mimicking high density, commonly in the posterior fossa, as well as other just general forms of pathologic high density that simply are not hemorrhage. So for example, calcification or dense tumors. our AI does not do a good job necessarily of excluding hemorrhage in these cases, and they do end up as false positives in our workflow. Similarly, the algorithm does miss hemorrhage. Those examples here of false negatives are shown on the right-hand side. By and large, these are almost invariably small volume subarachnoid hemorrhages that are missed. Anyways, it is certainly a limitation here that's worthwhile to acknowledge. The second algorithm here is the detection of a proximal large vessel occlusion. Our algorithm works on this task by first tracing out the relevant vasculature, including the distal ICA, the proximal M1 and proximal M2 segments, and then explicitly tries to look for an occlusion in that distribution. The algorithm performance, as you see here, is actually even more sensitive and specific than in the case of hemorrhage, with a positive predictive value of over 85% and a negative predictive value that is nearing 100%. As with all deep learning models, the algorithm is very fast. And in addition to identifying the areas of occlusion based on the vessel tracing capacity of the deep learning system, we're able to generate very high quality, interesting MIP images that help visualize the vascular anatomy very easily. I will point out that from a CMS reimbursement perspective, this specific tool, the detection of large vessel occlusion, is in fact one of the very first dedicated reimbursement codes for AI that the CMS has put out as part of this new technology add-on payment, the NTAP, announced in late 2020. The reimbursement code specifically is for the use of AI in large vessel occlusion detection for any inpatient who ends up accruing charges beyond what is typically reimbursed for standard of care. In these scenarios, the hospital is eligible for up to an additional $1,040 of payment beyond, again, what is traditionally reimbursed, as long as this type of tool is used for triage. And I will point out that this specific application, compared to many other types of AI tools that we have on the market, this application was targeted for reimbursement first because of that demonstrated improvement in patient outcomes over the baseline, as we will hear certainly later on today in the remaining talks. Finally, if you exclude hemorrhage and you detect a true proximal large vessel occlusion, then the decision ultimately for thrombectomy comes down to characterization of the ischemic core, trying to determine how much brain tissue has already died. There are several ways to do this. The simplest way is something known as the aspect score, which is a quantifiable metric to assess ischemic core based just on your non-contrast head CT. Our algorithm performs this task by first going through and identifying suspicious areas of infarct and then trying to quantify the degree of low attenuation and mass effect in that region. This algorithm is then able to generate a heat map of suspected areas of core infarct throughout the brain. And after superimposing an anatomic template over that map, we're able to generate very precise quantitative estimates of aspect score. I will point out that this task, as many human experts know, is very subjective. And so rather than outputting just a single score, we do give our users the option to change various thresholds and prediction to better align ultimately with what the human expert believes is consistent based on clinical presentation. The other method, of course, to assess for core infarct is CT perfusion. There are a number of non-deep learning methods for assessment of core infarct on perfusion that are very well established, and in many ways is something that we believe is perfectly satisfactory, not something that is absolutely necessary for deep learning to solve. That being said, we do have some early prototypes for evaluation of perfusion using a pure AI-based approach. In other words, skipping our standard RCBF or TTP perfusion maps and going straight from the raw data to the prediction of ischemic core. under the hood, what our algorithm is in fact doing is looking at the kinetic curves that are generated by a perfusion and looking at a pixel by pixel or voxel by voxel level for specific changes in this type of perfusion curve to predict ischemia. Using DWI ground truth to help train the algorithm, you'll see here that the AI generated perfusion maps in the middle are relatively high correlating to the ultimate area of core infarct. The maps you'll notice here are in fact much more higher in signal to noise and much more readily picking up the areas of infarct than you would expect in our traditional perfusion-based maps. The quantitative results are shown here, including a DICE score for spatial overlap of around 60%. And more impressively, if you go ahead and take these outputs and try to binarize the results to volumes of core infarct, so AI estimated volume of core infarct versus DWI, then in fact the Pearson correlation for estimated core infarct volume is nearly 88%, compared to just a 75% accuracy using more standard RCBF thresholding methods here. And with that, I'll go ahead and conclude. In summary, you'll recall that each one of these triage-based imaging decisions that one needs to make in a stroke patient, whether it's the detection of hemorrhage, proximal large vessel occlusion, or characterization of ischemic core, each one of these steps is in fact an opportunity for deep learning AI to help expedite and improve the overall clinical workflow. Putting these all together really gives us a unique opportunity to enable workflows and pipelines that we really wouldn't have been able to accomplish well without AI assistance. So with that, I'll go ahead and conclude here. This is my contact information. I know there's some time at the end for questions, but if there's anything else you'd like to follow up on after the session, I'm happy to chat further. Thanks again for your attention, and I'll turn it back over to our team. Thank you.
Thank you, Professor Chang, for this great talk. And I think you can just emphasize enough how important it is that health insurance companies recognize our efforts in using AI to just speed up patient workflow and reimburse our efforts on this topic. It's very important and good to hear and good to see how everything works. So as I said from the beginning, we are having the discussion at the very end. So this is the time to just switch over to Professor Kenneth Snyder. He's a neurosurgeon and associate professor at the State University of New York in Buffalo. And he'll share with us some insights on the management of acute stroke patients, including the interventional aspects. Professor Snyder, thanks for joining us, and I'm glad to hear your talk.
It's an honor to be part of this esteemed panel. I plan on giving a brief update on the American Heart, American Stroke guideline criteria, building off Dr. Chang's talk, talking about our experience in clinical practice with the automated programs and algorithms, and the finish with an incredible workflow opportunity by taking advantage of all of the Canon advanced applications in stroke. Very interestingly, our American Heart, American Stroke guideline criteria in the US had a modification to it a few years ago, specifically related to the use of perfusion imaging in less than 6 hours. It is no longer a recommendation or a requirement. And the reason for that, this is a complex slide, but it's a listing of 5 randomized controlled trials less than 6 hours out from onset of stroke, looking at medical management versus medical management plus thrombectomy. And if you look at the bottom of the slide where MRS is listed, the trials that used perfusion for selection of patients had the most benefit, 70% or more sent home independently. But for the trials that did not have perfusion imaging and used CT scan alone, there was still significant benefit based on that aspect score that was mentioned before, just ruling out hemorrhage. And it's because of that we didn't want to rule out the ability for people to have benefits of thrombectomy for less than 6 hours. We've been using perfusion imaging to select patients for thrombectomy since 2010, and doing that for advanced timeframes, 8 hours, well out to 24 hours and beyond, sending 30% of those patients home independently. Because it's been part of our main practice in Buffalo, it was really hard for us to recognize the importance of needing to do a randomized controlled trial. It's been part of our prospective practice here in Buffalo for a number of years. But that said, in order to change the paradigm around the country and around the world, 2 randomized controlled trials did need to occur. What that meant is that a 20-year-old individual with a NIH score of 15 or so, or 10 or higher, would, with viable brain on a perfusion study, would have had to been randomized. And that was an ethical dilemma for us. The trial, with no surprise, was stopped with tremendous benefit for the thrombectomy arm, with a significant benefit into the 12 to 24-hour arm of 44% versus 8% in terms of MRS less than 2. The imaging that was used in many of these trials did use a custom platform that has changed its thresholding over multiple years. It does define penumbra as greater than 6-second delay. It uses CBF as the main physiologic parameter for core or time delay greater than 10 seconds. And the thresholding is changed throughout different studies. The Diffuse 3 trial, which was stopped early, also showing major benefit in thrombectomy, used a core of less than 70 cc's with a penumbra to core ratio of greater than 1.2. This has become level 1 evidence in the United States. But then the next question becomes, what do we do to advance the field? We're fortunate to have an IRB at our institution where all of our patients are studied prospectively. But for other institutions, they follow this criteria. And as brought up by Dr. Chang, with multiple vendors out there, how do you align the thresholding with what was used in RAPID? These are the current thresholds for criteria and extended hours of treatment and the differences between the 2 trials. There's an NIH difference. The difference also is DAWN does not use a penumbral calculation from imaging. It uses clinical exam as a measure of penumbra, and then therefore Diffuse 3 does a ratio. So current state of the art of treatment is if within 4.5 hours, identify whether someone's a TPA candidate, identify if there's an LVO, and then using the DAWN and Diffuse criteria, enroll patients for thrombectomy. Again, we're fortunate to be in a prospective study center where IRB allows us to study well beyond this range. Dr. Chang had mentioned we have a Rapid AI and Viz AI both available to us, and we've been studying the Canon AI platform as well. So with the same raw DICOM data set, we're able to post-process with all vendors that are currently available and ask questions on thresholding as well. What I liked about the old PAT system was the ability to go in, remotely work through each of the algorithms, pick ROIs of interest, repick arterial input functions and venous functions, and really play with the data to get a feel and a handle on what we felt was viable tissue. The AI platform does an incredible job of automating that, but I like to be able to go back to the workstation and do a deeper assessment, and that's what allows us to do our post-processing review of thresholds. As was mentioned, perfusion imaging basically is 19 snapshots within 1 cardiac cycle or minute. Although we do capture the arterial, capillary, and venous phase, the capillary phase is where all the real main information is around the arterial, the tissue density function, which is used to do all the calculations to assess volume, time, and blood flow. What's important in looking at meta-analysis is the physiology and what the physiologic imaging teaches us. Whenever there's an occlusion, we know there's a time delay of blood flow to get to that distal surrounding territory that's vasodilated and works as a sump. There's blood flow reduction, but in the early phase, the vasodilatory component actually makes the brain hypervolemic. There's more blood on the side of the acute stroke compared to the normal hemisphere. And then following that loss of blood volume, eventually there's metabolic death. But realize we're using a intravascular non-diffusible tracer to make a surrogate assessment of what's happening inside the cells. To be cautionary around the penumbral calculations from imaging, this is a coronal image of an M1 occlusion with beautiful collateral flow with significant time delay. This patient had a minor TIA and has had this perfusion imaging for more than 2 years, neurologically perfect with no symptomatology even on exertion. I'm only bringing this case up briefly. I listened to Dr. Chang. I wanted to mention, with what our previous assumptions were on stroke imaging, acute thrombectomy has radically changed our learning curve on what is core and what isn't. This was a 29-year-old NIH of 17 that showed up on the left side with a very large DWI region. We emergently took the patient for thrombectomy, and this is the post-op image on the right side. The take-home message here is DWI imaging is not core imaging. The ATP pumps are shut down, the cell may be swollen, but if you're able to recover that tissue, you can get full resolution. And that's where the perfusion imaging really helps us. We did take the Canon AI LVO algorithm, which was trained on 3,000 cases, and we did our own accuracy assessments and studies on those and published those as well in Neuroradiology Journal with the accuracy and sensitivity specificity listed there. We saw tremendous benefits with the Bayesian CTP algorithm improvements in ventricle segmentation, thresholding improvements, summary map improvements, and an improved ability to pick the arterial and venous input function. Again, the only thing I'd like to say is you can go back and change these to really reassess your final calculations and see how much they may have been affected. We have about 2,500 to 3,000 perfusion studies a year on our stroke patients. Our idealized prospective data sets are a CTP followed by a rapid thrombectomy to TICI-3 and a flare at about 5 days, which we think is a good assessment of final infarct volume. We also get a perfusion study the second day. Along with its clinical data, all of its medication and lab data for approximately the last almost 15 years, we've been collecting this prospective DICOM stored database to be able to assess over multiple vendors. For an example of some of the discrepancy we might see or how a facility needs to be careful about making its decisions today, this is a 75-year-old seen well the prior day with an NH11 with a right M1 occlusion. Looking at this perfusion study, it follows a Dawn criteria in terms of its time frame. Because of that in the NIH score, we would have to have a less than 30 cc core to be able to take this patient for thrombectomy. The Vitria and Canon algorithm suggested a 13 cc core. When this was processed in rapid, their cerebral blood volume didn't calculate any drop. What's interesting, and we've seen this on a few cases, there was time delay of penumbral calculation in both hemispheres and even in the cerebellum. So any old strokes can show up as time delay and be incorporated into a calculation of penumbra. That 10-second delay of almost 90 cc's, which is considered core on that algorithm, would have made this patient ineligible for thrombectomy using the Dawn criteria. We take the patient for thrombectomy, perform to a TICI-3 result and immediate NIH improvement on the table, no significant DWI infarct with a flare infarct that almost matched the initial core. And this is how we do learning assessment with each and every case. We've published this in multiple journals assessing multiple different vendors from the same DICOM data set. I would like to bring up a case that I think teaches us that we have so much to learn on stroke and stroke imaging, and there likely will be parameters that are dependent on someone's age and other criteria. This is a 28-year-old who showed up likely from a carotid dissection just within 4.5 hours with the high NIH. He was given TPA, hypermedia sign, had a very low aspect score, lower than most criteria for treatment. We did see sluggish flow in the carotid and an intracranial M1 occlusion. The cerebral blood volume score was extremely low. Again, would have been thought to have been potential core based on all of those imaging criteria. And so in our facility, we brought this young patient in for thrombectomy. The carotid had completely occluded itself. We went up with an aspiration catheter and opened up that carotid. There was a lot of thrombus remaining in the carotid. We then addressed the intracranial M1 occlusion, went up with aspiration there. The minute that we opened up that vessel, the patient screamed out in pain and started vomiting. Of course, knowing that that was potential core, we were worried this patient bled into their head. We intubated the patient, did an on-table LCI image, no hemorrhage on the scan, put the patient back under angio, noticed that what before was open was now occluded again, throwing clot likely from the carotid, gave the patient dual antiplatelets on the table and stented the carotid artery. We noticed at the petrous end, the stenting was necessary right at the transition to the skull base, which required another wingspan stent. Then went up intracranially and took a look. Within a few minutes, we were concerned about the wingspan stent filling with clot. We ended up seeing that they threw a clot and ended up with a superior trunk occlusion. Had to give 2 half doses of integralin to reopen that back up on this patient. And so here's a 28-year-old with was likely dead tissue that got TPA'd, heparin, ticagrelor, aspirin, and integralin. Really would have expected this patient to never survive. The CT showed some basoganglia staining. The next day was an NH of 4 and has been neurologically perfect since. I think there's a lot to learn as we're applying these algorithms. Currently, we use the CT perfusion algorithm to tailor our treatment to what patient comes in. This is an example of core infarct in the cerebellum and hemorrhage in the PCA territory with the basilar occlusion. In that case, we go up and do a coil occlusion of the PCA territory that's hemorrhaged and open the basilar back up. We can't make the patient perfect, but we can make them as good as their perfusion scan. We're very excited about the entire workflow. A few months ago, we just installed the 4D CT from Canon, allowing us to get perfusion imaging and angiography in the same suite. Our patients don't even come into the emergency room. They come in through a stroke triage door right onto the scanner. If the scanner suggests viable brain, we bring the team in and do the stroke treatment right there on the table. This algorithm also will allow me to do single vessel distal perfusion imaging to start to confirm what we are thinking are our physiologic parameters on X-ray and actually measure them in 3-dimensional space. All of the AI workflow in Canon is built into this system. So we're able to not only take advantage of all of the dose imaging reduction and imaging enhancements of the CT scanner, but we're able to take advantage of the dose reductions on the angiography table in real time as well, allowing us to achieve extremely low radiation dose to our patients and our staff. We've co-built with the Canon team a FDA-approved high-resolution imaging detector, which lets us see images at a resolution that most places aren't able to achieve, either on our flow diverters or in our stent retrievers. We are again publishing the ability to use angiography to develop those perfusion algorithms on table, automated TICI scoring, and the ability to look at the CT scan and with its Hounsfield units determine what we're calling a perviousness or an ability of dye to go through the clot and try and predict first pass or choice of device due to what we expect the clot to potentially be. With that, I want to thank you all for the opportunity to present today and welcome questions at the end.
Professor Snyder, thank you so much for your amazing talk. It was really great to see how much is possible and how imaging interventions and patient outcome interact with each other. With this, I would like to go to our last speaker of the panel. Dr. Doche Laquintane is a radiologist, active in neuroradiology in Bordeaux at the University Hospital in France. And he's going to talk about faster workflow and improved diagnostic confidence and stroke follow-up with MR deep learning. Dr. Doche, please.
Good evening. So I will talk about faster workflow in improved diagnostic confidence in stroke follow-up with MR DLR. So I'm a radiologist based in Bordeaux. I'm working in private practice and I will talk about stroke, but away from emergency unit. I use a Vantage Galant system, a 3T. On the hardware part, I use 8 coils with 32 elements, and with also high gradients with a through rate of 200. And on the software part, I use deep learning reconstruction, ACE, which is the main topic of the talk, and other advanced acceleration technique like contrast speeder and multiband speeder. So ACE is the first deep learning reconstruction available for scanner and MRI. So ACE, the name is Advanced Intelligent Clear IQ Engine, DLR. So it's based on artificial intelligence, program with the capacity to learn and reason like humans, which is part of machine learning, which is algorithm with the ability to learn without being explicitly programmed. And all the deep learning is part of all this, and the deep learning will use artificial neural network, deep convolutional neural network. We will learn based on vast amount of data. So it's based on artificial neural networks. So first, there is a training part of the network. So you will give to the network based of deep convolutional neuron an high IQ image quality target image acquired with 10 NAQ, 10 average. And the network is fed with low signal to noise ratio input images. And it will learn to, based on the target of high IQ image, to denoise, to do denoising and to ameliorate the signal to noise ratio. So in clinical practice, you will use a validated deep convolutional neural network, a trained network, which is stabilized, which will not evaluate because otherwise your own system with the own noise of the system or the different way of the system is working could pollute the network. So the network is stabilized. There will be update of the network in time if need to ameliorate it, but there is no problem with a kind of pollution of the capacity of the denoising system due to your own system. So the integration in routine practice is seamless, it's very easy. So the point of this is to do a deep learning reconstruction, so to do denoising. So the idea is to compare a convolutional filter with ACE. In convolutional filter, on the subtraction, you will miss some clinical relevant information. Here you see that you have some anatomical details which are missing, which are in the subtraction. So you will lose some clinical information after a subtraction. But with ACE, on the subtraction, you have only the noise. There is no relevant clinical information after subtraction. So the signal to noise ratio is better. So practical example, this is a 3D flare. With no ACE, we were around 5 minutes 50 seconds. With ACE, with R at 2 minutes 51 seconds. So we save a lot of time thanks to the denoising. And also the resolution is better. You see that the differentiation between white and gray matter is better. And the signal of the white matter is more homogeneous. So another example of a 3D flare, it's a zoom on the temporal lobe. You see better the collateral sulcus, for example. On the hippocampus, you are able to see better the stratum lacunosum, this small black line. And the demarcation between gray matter and white matter is better, it's more sharp. So another example, you can also use the DLR to save time, or you can also use the DLR for the same amount of time to have a better resolution. Here is an example of susceptibility imaging, FIBB. You have here a small microbleed in the right cerebellar, and without ACE and with ACE, you see that the demarcation of the microbleed is more sharp, is more well defined. So the resolution is better. Here it's a bit blurred, I think. Another example of acceleration technique is the multiband on DTI. We were at 2 minutes 22 seconds, and now we are at 1 minute 16 seconds, 50% time saved. So with ACE, the amount of reduction of time is between 27% and 55% in the more efficient situation. So for example, a 3D flare that I will use its stroke was before 4 minutes 40 seconds, now it's 2 minutes 15 seconds. Another example is the susceptibility FSBB. It was 3 minutes 38 seconds, now it's 1 minute 41. And then 3T1 MPH, 2 minutes 42, not 1 minute 42. The point is that here it's a kind of standard protocol for stroke or headache, and it's around less than 7 minutes. Just here to see about ACE, D3, it means that it's the amount of native image and denoised image. D3 is around 50-50. So it's a usual way we do it. And 1.8 or 1 is the system of denoising. It means that if you have at 1, you are very conservative. If you are at 1.8, you start to put the system more to its limit. So it means that also when you start to use ACE, you will go by trying yourself what you think is acceptable in quality after saving the time. Another example of acceleration technique is compressed speeder. So the compressed speeder is based on undersampling of the K-space. You use a regularization factor, and the point is to separate the redundant information, the tissue signal, from the aleatory information, the noise. So again, it's a trade-off, because if you push too high the regularization factor, you will have less tissue signal, and the quality of the image will be less good. So here there is no AI on compressed feeder. So with compressed feeder, the reduction of time acquisition is between 42% and 53% in the more efficient situation. So for example, a 3D T1 gradient echo was 240 seconds, and now it's 1 minute 29 seconds. And 3D spin echo was 3 minutes 28 seconds, and now it's 1 minute 56 seconds, sorry. And the multiband, like I told you before, it's around 50% saving time, and it's based on the simultaneous acquisition of two slices. The point is that the accurate signal contains information of two slices, so you save basically 50% of time. So clinical cases, just to show you that the resolution is good. It was a woman of 84 years old, and she had a right arm hemiparesia and a right facial weakness. So you see that it's kind of atrophy in the parietal lobe, some eye signal in the centrum ovale, with some lacunar infarct, old one. And here you have a small recent subcortical infection in the superficial territory of the middle cerebrolateral artery, with eye signal on the white matter and a low ADC restriction of diffusion. And so here it's a kind of Willis with also the carotid, what we try to do when we are looking for stroke. And this protocol is a standard protocol for stroke. It's a sagittal T1 with ACE on 2D, 3D flare with ACE on 3D, 3D TOF, FIBB with ACE, and you see that it's around 7 minutes 42 seconds. And we try to do a Willis with a supraarterial trunk, and see that the quality is quite good, and we have a good looking at the bifurcation of the carotid. Yes, it's another example with a repetitive discomfort with a small stroke in the Sylvian superficial left in the precentral gyrus, and you see that the resolution is enough to see a small low zone of restriction diffusion with low ADC just here, and no microbleed. Another example is here. You have a Parkinson syndrome due to a left Sylvian superficial stroke. So you have a parencephalic cavity with gliosis around, and on the orientation color map with DTI, you are able to see that the left corticospinal tract is less defined on the posterior part, and with the tractography, you see that the posterior part of the left corticospinal part is missing. It's due to Valerian degeneration. So last example, it was a woman with an episode of acute dizziness 3 months ago, and you are able to see a very small left cerebellum ischemic lacuna with good quality of resolution because it's very small, and the low ADC, and the high ADC because it's an old infarct. So the perspective, it's a balance between time gain and resolution gain. You will first improve your patient workflow, but you will also improve your diagnostic quality. So you have more time available for more sequences or more patients. So you will ameliorate the waiting time for a patient. You are able to do more easily some advanced application like spectroscopy, perfusion, T1, perfusion T2, ASL. So by using all this acceleration technique like CS2D, CS3D, multiband speeder, but also you can also combine DLR with CS, use it probably synthetic MRI in the future in 2D and probably one day in 3D. And the idea of all this is to have a 70 quality with a 3T magnet. So you will improve the workflow at 1.5 and 3T. So for example, here on 1.5, we try to do 4 examinations by hour by an alternance of examination with contrast, 2, and then 2 without contrast. And on 3T, we try to do advanced application in 30 minutes and then 2 more quick examination in just 15 minutes. And so you see that the routine protocol is around 6 minutes 49 seconds. And for example, a protocol a bit longer for epilepsy, it's 8 minutes 37 seconds. So the takeaway message is that faster workflow and improved diagnostic confidence in stroke follow-up. It's now possible with new acceleration techniques due to deep learning reconstruction, compressed feeder, the combination of the DLR, the ACE and CS, which is working at 2D and soon will work at 3D, but actually the reconstruction time is a bit long. So maybe in the future it will be better. So thank you for your attention.
Thank you so much for this amazing talk on MRI imaging, Dr. Doche. We will have the discussion right now, so please feel free to enter all your questions to the question and answer section within the Zoom client. And right from the beginning, I'd like to ask Professor Chang, do you see that there are many more updates on brain hemorrhage detection and large vessel occlusion needed to even speed up things, or maybe to achieve higher precision? Or is it just that we are going to focus on other aspects in radiology with AI and deep learning technology?
That's a good question. So I will absolutely admit that the algorithms are not perfect. There's quite a bit of room for improvement. What I would notice is that in general, the algorithms work very well when the data that it sees is similar to the types of images used for algorithm training. But as you move into community hospitals or other places where imaging protocols really are not standard and don't look at all like what was used in training, we're having issues. So this idea of making models that are better generalizable and used to looking at images from any manufacturer, that's certainly one issue that's very active. Similarly, machines evolve and scanners change. So as the technology for the scanners get better, if we have, for example, a new DLR improved image that becomes standard and common, our AIs currently don't adapt to that new technology. So developing ways for the AI system to on the fly improve themselves, understand new imaging protocols, and get better, that's another very active area of research that we're working on.
Will that be the risk that if you receive for example, a simple software update on your machine, which changes kernel reconstruction type or anything else, that our algorithms won't be that precise anymore?
That's correct. We don't know. Sometimes it works well, but oftentimes a minor update that seems trivial to us ends up completely ruining or making your algorithm, perform a lot worse. That's a very active area of research, understanding how to detect that, right, without needing a human to flag it and say something's going on. Can the AI itself know that this image just doesn't look quite right? That's a very active area of research. I think it's something that we're excited about. It's something we're also working very closely with the FDA to understand how to regulate such algorithms that continuously update and things like that. But anyways, in my opinion, that's really part of the secret to taking AI to the next level, right? We're looking at AI right now and using it in ways that software has been used for 50 years. How do we actually take advantage of the new technology? And I think this is one of the things that we need to solve.
Thank you so much. As I don't see any more or any questions from the participants, I'd like to ask the next question to both of you, Professor Chang, Professor Snyder. As interventional radiology becomes better and better, and neurosurgery does on the same level and even beyond get better and better, you will be able to treat more distal vessel occlusion as we do it now. So is there the need to create more algorithms which do not only address large vessel occlusion, but is there the need for small vessel occlusion in neuroradiology? And of course, will it be possible? Because the smaller the vessel becomes, the harder it will be to detect.
I'm happy to start. We're currently engaged in those trials. I think we underestimate the power and the importance of IA clot-busting drugs into that distal territory and tissue. We also have novel devices made for sub 1.5 millimeter devices that are out there. I think the challenge of what starts to happen when you get very distal, first of all, we underestimate the importance and devastation of a small vessel stroke in the wrong location. If you have a receptive aphasia that completes itself, you are lost to the planet. You are unrehabable. And so it is important to be very aggressive about certain distal strokes, just as it is around an LVO. And I think what's also important is crossing the clot before you attempt to remove it and looking at the distal vasculature. Because once you get far out like that, you can end up with a whole distal territory that's filled with clot. And therefore, just trying to pull a plug out does you no good because there's clot all the way out. And again, IA, I think exploring with intraarterial TPA and other, this is the area of research that we're looking at right now and exploring.
That's right. And from an AI perspective, absolutely. We're starting with, M1 and proximal M2 because it's easy, right? And it's something that generalizes well to many different hospitals. But absolutely, as soon as folks like Professor Snyder tell us it's important, it's our job to make those algorithms. So, and there's no reason that the technology itself, the deep learning systems can't do this. We just need to work on it.
What will probably start to revolutionize the field is if we get away from non-diffusible tracers and get to being able to bring back xenon and other things, gas diffusible tracers, because now we'll have an exact metabolic measure that will be much more reliable for our patient selections. So again, that type of advancement would revolutionize stroke.
So, Professor Chang, what is the actual limit of vessel size detectable, truly detectable and stable detectable by AI from a diameter perspective?
The theoretical limitation is really not the problem here. As long as you have relevant data to train the model, you'll be fine. Our limitation in making the first generation of algorithms is the fact that M2 and M3 occlusions just aren't that common, or at least they're not commonly reported in the radiology workflow. So we don't have a lot of those examples to feed our algorithms. As you get to the smaller vessels, as you might imagine, the appearance also changes dramatically, more so based on manufacturer and protocol, venous contamination, whether you have a good arterial bolus, right? All these things just add some complexity and variability to the process. But by and large, if you have enough training data, an algorithm can learn the relevant patterns. So it's not a problem with the technology, just we have to get the data and we have to execute in building that algorithm.
From my personal experience, I know that patients with an acute stroke rarely tend to lie straight and do not move, which is horrible for MRI imaging more than it is for CT. So maybe it would be a great challenge to tackle within the next years or so, to be able to get algorithms working on moving patients, even if it's a slight move. I think each and every algorithm will fail at the moment of today. But those are the real life scenarios where those patients are agitated, are seeking for help, and don't just lie down straight like a non-stroke patient does. Maybe this is something which will be interesting in the next years. We do have a question or questions from the audience, and I'm happy to read it. So when or if MRI is used in the stroke onset protocol, what is the standard of care for clearing a patient for MRI when they are not responsive? I guess this is to Dr. Doche, mentioned to Dr. Doche. So how do you do that?
Can you repeat, please?
So if you have a patient with acute stroke onset and he's not responding to what you ask, how do you clear him for MRI imaging to rule out there are any contraindications for MRI?
It's a complicated question. I hope there is somebody with him who can help us to tell him about the eventually contraindication, but I think you will do a CT in this case because you need to time is brain, so you need to go to the quickest solution. So I don't think you will pursue the MRI. I don't know what you think of both of you.
Agree completely.
Yeah, it's in the rare situation where you can get an MRI very quickly, our standard, regardless of stroke or other disease process, would be something like an X-ray, just to exclude, metal implants or other things like that.
Yeah, the least thing to do is to make more harm to the patient. So just go the safe way, I guess. So there's a second question to Dr. Doche. What's the main limitation of MRI stroke imaging to be used more routinely in clinical practice?
What is the, sorry, I didn't hear you well.
What is the main limitation of MRI stroke imaging in clinical practice?
You mean in
if there is
unit? If I don't have a big experience of emergency unit, but I guess that you will go for the most quicker solution to have a diagnostic. So probably I think that most of people use CT actually with perfusion. MRI is good, but you know, when I was talking about the protocol, it's around 7 minutes. So I think it's still long in comparison to scanner that you will do in 1 or 2 minutes. The other point is that you can use perfusion or ASL with MRI, but again, it takes time. So I guess that most of you use CT, and you were talking about CT and less MRI. And MRI for follow-up is good after the machine unit, I think, but time is brain, so I think CT for the moment has the upper part. But I'm not a specialist in emergency unit, but I guess that by listening to all of you, that's the answer.
One thing I'd like to add, and Professor Chang may comment more directly, there's an inherent difficulty in that perfusion imaging and MR is nonlinear in its analysis, and CT is linear in terms of its signal. That adds a whole nother dimension of complexity to being able to do thresholding and do analytics of the assessment. And so although MR is important and helpful, especially for small stroke or diagnosis, there is a clear role right now for CT perfusion. The other point I wanted to bring up is the importance of not intubating a patient if you don't need to. These patients are auto-regulating when they come in. They're vasodilating and they're driving their own blood pressure. Their brain is deciding how much blood it needs. The minute you intubate a patient, you're now dependent on an anesthesiologist for blood supply. And that is, we've learned the hard way, that is not ideal. And so again, to intubate a patient for imaging is also a major problem if you can get away from it.
That's right. I essentially agree with what my colleague said. It's just very rare. In the United States, I know of maybe 2 or 3 centers in the whole country that start with an MR-based triage protocol. And it's because they have an MRI dedicated stroke imaging in the ER that they can roll the patient straight in and get that done right away. The vast majority of centers don't have that capacity. And then even if you have it, there are the complications that were mentioned. So absolutely, it's a CT first by and large.
We have another question, I think aiming at Professor Chang. A bad positioning of the head of the patient in the CT, does it affect your AI solution or any AI solution on the market in detection of stroke?
So yes, it potentially can. Our algorithm will actually reorient the patient as soon as the images are acquired. So we take the raw 3D volume and then we actually make sure everything is anatomic before we analyze the studies because of that reason. I don't know what the other solutions in the market do for this, but if it were compensated for, absolutely you'll have problems analyzing the study.
Adding on this, I would like to know if anyone knows, has any experience or knows any literature on what happens if you just open up your scan field of view on your patients because he is placed incorrectly or is moving, and you say, okay, let's take a larger field of view. So you'll lose in-plane resolution. Does this affect AI and further analytics?
Yeah, it does. It depends on what you're looking for, right? So subtle hemorrhage or very subtle findings on CT, you're going to miss if you start to open up the field too significantly. Remember that it's not just the matrix size that's changing. Your dose calculations for how much radiation you need to apply to the patient completely changes. You need to penetrate more tissue. So all these things end up complicating the situation. That being said, a lot of things that we need in stroke triage, they don't actually require a lot of detail. So, our perfusion data, for example, is acquired in a very coarse type of way, a very coarse resolution. So it's interesting. I'd be curious. I don't know what the exact amount of degradation would be if you did that strategy, but I imagine it may actually not be as much as we think.
I think building off that comment, I think what's important for people to understand is a lot of the perfusion imaging is for people with severe NIHs that you're going to potentially take for treatment, that you really have a high probability that there's an LVO. For your low NIH presentations, those will all go to MR, and you'll be able to get that and do those comparisons.
Thank you so much. Okay, we are perfect in time. thank you all for your great talk, for the impressive cases, and for the discussion. Thanks for Canon for making this webinar possible and allowing all of us here to present. Thank you for attending, all of the participants. I'm happy to say that there will be a certificate of attendance which you will receive approximately 2 weeks from now by email, the email you used to get the invitation. And please, as there are more sessions coming up from Canon, please have an eye on the Canon webpage, because there are further details on upcoming talks and topics which are as interesting as today's session was. Thank you to all the panelists once again for joining, and thank you all for attending. Have a great day, have a great evening, and hope to see you soon. Goodbye, everyone.
Bye. Thank you.
Thank you.